Okay, I think we can go ahead and get started. I want to thank everybody for joining us today. This is our third installment of the Rutgers RWJMS Department of Medicine Grand Rounds that is now taking place. It was started initially by the Division of Pulmonary and Critical Care Medicine. They undertook this about a month and a half ago in response to the change environment with the pandemic and ensuring that we were still providing some education to everybody on the faculty about COVID-19. And we've started this a couple weeks ago so that we can continue to educate everybody about COVID-19 and do it in a way that is encompassing all the different disciplines. So we started out, we had a great session a couple weeks ago with Claire Phillip talking about coagulopathies. We had a great session last week with Ira Bedzo from New York Medical College talking about bioethics and taking care of patients with COVID-19. And today we are incredibly lucky to be joined by John Kush, who is a professor of medicine and internal medicine at the University of Texas Southwestern Medical School. He's also the executive editor of Rheum.now and the co-editor of Rheumatology.com, which hopefully he'll be able to show those himself when I turn it over to him. But one thing before, and the other person, of course, who's going to be presenting the case and helping to mediate is Carlos Osorio, who's one of the group of amazing fellows that we have who have committed their lives and their health over the last 6 or 8 weeks to taking care of our patients. And Carlos, to you and your colleagues in the Division of Pulmonary Critical Care Medicine and all the fellows and all the residents and interns, we thank you for everything that you've done. And it's amazing that with everything that you've been doing, your devotion of time and effort, that you're still able to put something together to educate everybody. So thank you. Before I turn it over to Carlos, I wanted to show you one thing that is at the bottom. And Dr. Kush, I hope you don't mind that I do this, but Dr. Kush's signature for his email, he has a quote. And I don't know if he recently chose this quote with the pandemic, but it's something that strikes me as incredibly appropriate for what we are going through. And it's a quote from the movie A League of Their Own. And the quote is from Tom Hanks, which makes it even more ironic that Tom Hanks is the biggest star to have contracted COVID-19 that we know of. And the character, he's a coach in this movie, and he says, of course it's hard. It's supposed to be hard. If it were easy, everybody would do it. And hard is what makes it great. And I think it's a great takeaway for all of us that what we're doing is incredibly, incredibly hard. And there are lots of people out there that would love to be able to help our patients, but they don't have the ability and the talent and the skills that you all do. So thank you for what you're doing, and what you're doing is great. And so now I will turn it over to Carlos and he can present the case.
All right, let me see if we can transition over to sharing the slides and everything smoothly.
Oh, Carlos, sorry, while you're doing that, I'll make an announcement that on the chat board, what I'm gonna do is I'm gonna make it so that you can only chat directly with me. And during the case and the presentation, if you have any questions that you want posed at the end, send me directly a message, and I will, after Dr. Kush is done with his presentation, I will ask Carlos and Dr. Kush what those questions are so we can have a fruitful discussion. Thanks, Carlos.
All right. Okay, I think we're sharing it now.
Yep, perfect.
Okay, I just have to figure out how to click next slide here, and I think we're good to go otherwise. Okay.
Yep.
Well, I just jumped one slide, so I guess we'll have to go back to the original presentation. But in essence, it's a 40-year-old male, Hispanic male, who presented from home. His initial presentation was that he had been with high fevers at home for about 5 days. And finally, when he developed shortness of breath, a day prior to presentation that wasn't improving, just getting worse at home, he came in. He was having a cough. It was a non-productive cough. and with those symptoms he presented. He didn't check his actual temperature at home, but he had the symptomatic subjective symptoms present. No prior past medical history. Doesn't look like he was following with anyone routinely, but no prior medical history. No allergies, only prior surgery or remote appendectomy. As far as social history goes, Hispanic male, lived with his wife, no toxic habits, and no other surrounding history that would be contributory to what was going on. So he came in initially on presentation. He had a fever to 102.9. Heart rate of 98, blood pressure was within normal limits, a little bit high, 144/75, and a respiratory rate elevated at 24. On ambient air, his O2 saturation by pulse oximetry was 96%. And with 3 liters of nasal cannula, this improved to 100%. On exam, it was largely an unremarkable exam, except for the fact that his lung sounds were diminished and there was some scattered rales. But otherwise, no significant distress, and otherwise, again, unremarkable exam. There we go. Okay, so on labs when he first came in, top left, we have his CBC, which showed a hemoglobin of 14, platelets of 199, no elevated white count. His lymphocytes were 10. His coag panel was normal with an INR of 1.2, mildly elevated PTT at 31. His inflammatory labs that we've been checking for our COVID patients, and all of them were high. So LDH a bit elevated at 360. Ferritin was high at 1300. CRP elevated as well at 8.9. Fibrinogen of 1 greater than 1000, and a D-dimer a bit elevated at 670. So I'll ask that you remember these because they are our starting values for his course. Otherwise, his liver panel showed a little bit of an elevation in AST and ALT, which we have been seeing with some of these patients. His BMP was largely unremarkable. He had no lactate. His initial troponin was negative. Blood cultures were negative. UA was negative, and his COVID test was, of course, positive. Here's his initial EKG, which just showed a normal sinus rhythm of at 92 beats per minute. T waves are all up, and no hugely significant abnormalities there. And his initial X-ray showed these bilateral patchy alveolar opacities, bilateral, and we'll go through a few more X-rays through his hospitalization, but this is how he first started. So initially he was admitted to the floors under a telemetry service with a diagnosis of COVID pneumonia. And he was treated initially empirically with vancomycin, which he had received in the ED. But soon after he was admitted by the very next day, so he came in late March 23rd. By the next day, he was already with worsening shortness of breath. Initially, I had said he was 100% on 3 liters. Now he was saturating 92% on a non-rebreather. He had walked to the bathroom and desatted and felt very short of breath. So his symptoms had certainly worsened rather quickly. Additionally, he was also treated empirically at this point. He was started on hydroxychloroquine and azithromycin as for a planned 5-day course, which he would complete. And with the picture as it was, with blood cultures being negative so far, procalcitonin at 0.2, so that gray zone, all the other antibiotics were stopped and the focus was managing the COVID. So he was on the non-rebreather. He was also placed on high-flow nasal cannula for the treatment of the hypoxemia, but he continued to worsen. His respiratory status deteriorated, and he was more visibly short of breath, more tachypnic, and that triggered the transfer to the medical ICU. So on the 25th, hospital day 3, he went to the intensive care unit where he was pretty much immediately intubated and being at that point ventilated with lung protective ventilation. He was given paralytics. He was also treated with some proning cycles. Now with that, as you can see, we can take a look at his oxygenation, looking at his PaO2. He did have improvement. You can see with the vent, he was a PaO2 of 352. And he was quickly weaned from 100% FiO2 down to 80, 60. And for the large majority of his hospitalization, he didn't require more than an FiO2 of 40. There was some issues with his PCO2. As you can tell, it was a bit elevated, which is another finding we have seen in these patients. But it wasn't to the point that it was, at least not initially, not to the point that it was causing much of a pH disturbance. So this is a post-intubation X-ray immediately post. So if you compare it to the first one, say two different, maybe better ventilated, better aerated. The lung spaces look a little bit better inflated, I would say. And we see the persistence of those alveolar opacities. Now, the day after intubation, it looks a little bit more opaque. We could make the argument that it might have been due to lower or smaller lung volumes and this specific exposure, but we maybe get a sense of some degree of progression. For the course of his hospitalization, the X-ray didn't really worsen much more from here. It kind of remained stable, I would say. What we did know was that he had an elevation in his inflammatory markers. So starting from his admission, remember the numbers here look relatively low initially, as shown here on the 23rd on his first day of admission, but those were elevated if we think back to the original graph. So they just relatively, with the increase, they don't look that significantly high, but they were high. Over to the 26th, when I just showed the worsening X-ray, we see a bit of an increase in his D-dimer, a slight increase in his LDH, and his CRP was also uptrending. So we start to see the beginning of that inflammatory response. With that increase in his inflammatory markers, on the 26th, he received tocilizumab. For reference, his IL-6 levels before administration of the tocilizumab were 74, and then these continued to progress to 345 and eventually to 400. On day 5 of hospitalization, the patient developed worsening hypotensive shock. At this point, he first required norepinephrine, and there was a question of what was causing this. There was a concern for possible myocarditis versus myocardial ischemia, and this came to fruition as a question since his initial bedside echo, when he was first requiring the vasopressor, showed what looked like some global hypokinesis. So that's where that question came from, and also there was an increase in the patient's troponins, and as we can see by the EKG, there was some depression, some ST depressions on the lateral lead. So there was a question of, is this cardiogenic shock? Could there be an ischemia picture? It was a bit unclear. So with all this, the patient was placed on the Levophed. An official repeat echo was ordered. A pulmonary artery catheter was placed. And with all these interventions, it looked like it wasn't quite cardiogenic shock that the patient was dealing with. We had a pretty normal CVP, an acceptable cardiac index, an acceptable cardiac output, and the official echo ended up showing that there was a normal LV function. Now this was on Levophed, but regardless, that's the information that we had. As his course continued, we can see that things deteriorated significantly. So remember, at this point, he's on a little bit of Levophed. He is being treated for what looks now like a septic shock picture, with this rise in these inflammatory markers, and there's a concern of if this is potential cytokine storm. He had received the tocilizumab, but he continued to worsen. He went into renal failure. We can see the rise in his creatinine and an abrupt drop in his bicarb. As this was happening, so initially when that troponin rise occurred, as part of the concern for the cytokine storm, there was a coincident rise in his temperature. So he actually had a temperature of 109 degrees Fahrenheit and a heart rate of 170. So if we can follow the graph here, there's two graphs. The top one we can ignore, is this white count. I want to focus on the temperature curve, which is the second one, the one below. His temperature He had a few fevers. You can tell that he was 102 at times, 101, and then the times preceding his 109 spike really wasn't that high. And then we see this sudden abrupt increase on March 28th when he had that temperature. When this occurred, he was placed on a coolant blanket. He was given dantrolene, and for that bicarb that we saw earlier, he was being treated with a bicarbonate drip as well. With all this, he significantly deteriorated. On the 28th, when he had this spike in temperature and all this was going on, the levofed was no longer enough. He had to be placed on 0.04 of vasopressin. He was started on epinephrine and neosynephrine as well. He was on 4 repressors. These were maxed out through the course of the day. And at this point, it was more than what he could tolerate, and he did expire. A conversation was had with the family, and he passed away on hospital day 7, I believe it was. So that will conclude my portion of the presentation of the patient. And if there's any questions, I guess we'll take them. I don't know, as you see fit, Dr. Cohen. And I'll yield to Dr. Kush to present the next part of the talk, where we'll be focusing on the cytokine storm.
Thank you, Carlos. Yeah, everybody can submit questions directly to me, and I'll pose them to Dr. Kush and Dr. Osorio at the end.
Should I stop the screen share at this point, or how does this part work?
You can stop the screen share and Dr. Kush can take over.
All right.
Hello, everyone. It's a pleasure to be here. I want to thank Dr. Cohen for the invite. I'm not an expert in cytokine storm. I do treat a lot of patients with macrophage activation syndrome. I'm going to cover a lot of the drugs that we use in rheumatology quite routinely, and why and how they're being studied in the COVID-19 infection and the cytokine storm, and give you some of my perspective on those agents. Let me see. There we go. So this particular case, it's unclear we don't have an autopsy. It's unclear what the terminal events were. Clearly, a temperature of 109 and a ferritin of 40,000, you would think cytokine storm as a real possibility. You considered myocarditis and cardiomyopathy. Another one that's out there and has, I think, a growing momentum these days, because very few of these patients, when they die, are really dying from COVID, the virus itself. They're usually consequences of the infection and downstream events and basically damage. So that's largely what happens in the cytokine storm syndrome. Also in there is this issue of thrombotic events, and specifically thrombotic microangiopathy. Brodsky and colleagues at Johns Hopkins are working on this. He's got a paper that's on that reference from my website about this, looking a lot more like a complement-mediated thrombotic microangiopathy, and not so much like DIC. In many ways, it looks a little bit like the complementopathy associated with the catastrophic antiphospholipid syndrome. These patients have an anemia, thrombocytopenia, organ damage, which is often terminal, and then very high LDH levels. So it's thought that these microthrombi are mediating the dysfunction. We do know that the coronaviruses can activate complement through the lectin pathway, and with complement activation comes a lot of damage. And now we have, C5 inhibitors, eculizumab, that's commercially available, but is also in clinical trials of patients with COVID infection. So while we're going to talk about a lot of biologics and the drugs that are being used, I don't have any results of any trials of these agents in cytokine storm. I have it in severe patients, whatever that means, and I think you should consider that. Adding to the risk of thrombotic disease are reports from mainly New England Journal, 2 different reports about antiphospholipid antibodies, IgA antiphospholipid antibodies, and beta-2 glycoprotein 1 antibody associated with 3 patients who have CNS demise and thrombotic strokes. And now more recently in yesterday's New England Journal, a report on 20% of the patients they assayed were found to have a prolonged PTT, and a subset of those that were assayed were found to largely have lupus anticoagulant activity. And whether only one of those cases, however, that they were screening had well, they had 2 thrombotic events. So it's unclear if that's going to be clinically relevant, but nonetheless, this is on the table and a potential contributor to terminal events. I did look up the issues of autopsies and what's found. In the liver, there's evidence when it's involved of hepatic necrosis. That's often what you see with the cytokine storm and macrophage activation syndrome. A nice series looked at 21 patients with respiratory failure and COVID. They had a lot of diffuse alveolar damage, capillary congestion, microthrombi, despite being on anticoagulants. While half their patients did have evidence of bronchopneumonia, there were also cases of pulmonary embolism, alveolar hemorrhage, 3 cases of vasculitis, and 3 with evidence of thrombotic microangiopathy. Another series from Germany looked at their autopsies and found what you'd expect: common comorbidities, coronary artery disease, asthma, COPD, but they did have DVT evident in more than half their patients, and 4 cases of them had PE. There are reports out there of myocarditis, as you know, not many of them sort of single case reports so far. So with that, I'm going to get into my stuff, and I want to start out by apologizing for everything I'm going to show you, because it's all sort of like sketchy data, meaning right now most of the really good stuff or press worthy stuff out there is not what we usually would be talking about, which would be peer-reviewed journal reports. Instead, a lot of the early clinical trial data is, in fact, press releases either from companies or the researchers. They're preprints. They haven't been reviewed. And the problem is that most of this is not peer-reviewed, and a lot of it's not even really in reputable journals. Most of the data is observational. While there are many trials going on right now, I think I counted 81 hydroxychloroquine trials and 33 chloroquine trials just in clinicaltrials.gov. Most of what we're seeing right now is the stuff that's not yet ready for prime time. Interestingly, when I started working on this a few weeks ago, everything seemed to come about the day before, and even yesterday, we have a number of reports that I included in this presentation. The impressive thing about these reports, and the ones that did go to good journals and whatnot, is the impressive timelines. From the time that the trial was thought of, enacted, completed, and published is lightning fast compared to what we're used to in academia. And lastly, I'll say that I don't really have any trials on things we'd like to look at, like cytokine storm or even prevention trials, but again, those are in the works. A lot of the drugs that have been advocated for use in COVID-19 are rheumatology drugs. Chloroquine, hydroxychloroquine. We don't use much chloroquine anymore. We use a ton of hydroxychloroquine. There's IL-6 inhibitors I'll talk about. JAK inhibition is in the mix here and should be considered. There are a number of IL-1 inhibitors that are out there in clinical trials, colchicine, and even GM-CSF, which would be a very important and potent agent in especially the cytokine storm syndrome, but no results yet. That's just in a few clinical trials. I'm going to start with antimalarials. You know, many consider them to be quite boring. I consider them to be amongst the safest. Hydroxychloroquine amongst the 3 safest drugs that I use in practice, meaning I got to give it to hundreds of patients before I start getting problems. The equivalent dose between hydroxychloroquine and chloroquine is 400 of hydroxychloroquine and 250 of chloroquine. At these doses, we don't see a lot of the things that many of you are concerned about, especially cardiac abnormalities. We don't do EKGs. We don't find cardiac issues. Arrhythmias and complete heart block just don't happen. But maybe it's because we tend to use the lowest possible dose, and we dose according to weight. The drugs are approved for RA, lupus, discoid lupus, and malaria. Only chloroquine has an indication for malaria alone. Now, how they work is kind of why they're being considered, in that these drugs will basically raise intracellular pH, and especially within lysosomes and endosomes. And endosomes are very important in the virus, the COVID virus gaining access after it binds to the ACE2 receptor. It is internalized through endosomes, and the acidic pH there basically destroys either the bug, as it does in malaria, or destroys the function of what that bug is trying to do. Along the way, with chronic dosing of hydroxychloroquine, we do have issues with or results that result in less cytokine production, and it's a low-level cytokine inhibition for things like TNF or alpha interferon. But it also has been observed to be a fairly effective inhibitor of toll-like receptor signaling, especially TLR7 and TLR9. And lastly, it's been shown to inhibit the glycosylation of ACE2, which could therefore make the bug unavailable to the cell, and might be one reason why it would work. Now, again, I said it's one of the safest drugs that I use. And I'm sorry, this is a really busy slide, but I want to get sort of the basics of antimalarials out of the way. Everything I have listed here, I've largely never seen. You know, in the last 100 patients, I've given hydroxychloroquine. I might have had one patient with abdominal cramping, nobody with a headache. I can't remember the last patient who had an itchy rash, but it does happen. These are not serious, but those are the most common. The things we worry about are the irreversible retinal toxicity, the maculopathy, the rare neuromyopathy and cardiomyopathy. They can do other things rarely, including change skin color and affect the hearing and occasionally blood cell counts. But the hypoglycemia, I've never seen it. I had to read the package insert in detail to find that one. But it is the retinopathy that leads to our main concerns. And as such, patients need to have a baseline eye exam, which used to be just a visual field testing, and now are these spectral optical coherence tomography tests, which are easily done, very detailed, and sort of change the game. But if you look at the graph on the right, you can see the evidence of retinal toxicity in the first 5 years is incredibly low. So the guidelines on monitoring here are that they get a baseline. If they have a normal baseline, we don't see them for 5 years. Now, it's been hard to get rheumatologists to adopt this, because it used to be that we would do this every 6 months, and a few years ago, 10 years ago, we relaxed this to once a year. So some are adhering to this, but the bottom line is you do it at baseline, 5 years, and then every year after that, because there is a rising and cumulative dose related incidents over time. The drug is very well absorbed. It stays in the tissues a long time. The antimalarials have a half-life of either 30 to 60 days, depending on the patient and the conditions and the dosing. So these are the things that everyone worries about, these toxicities. And as I said, these are really rare. And that line in there of cardiac toxicities, including prolonged QT intervals, widening of the QRS, heart block, cardiomyopathy, you'd have to talk to 200 rheumatologists to find one case, I think, of this. But then again, we try to use the lowest dose. Most of our patients are on 200 to 400 milligrams of hydroxychloroquine a day. Neuromyopathy does occur, and that can be proven by muscle biopsy. And then worsening of psoriasis is one of the reasons why we don't use it in psoriasis. But again, the drug is very well, G6PD deficiency is a supposedly worry. It's not a worry. It's almost never been described. There's one case report in all the literature. Now, it's a lot about toxicity, but the fact is it's a very safe drug the way we use it in low doses, and it's incredibly effective. This is like the cornerstone of therapy in lupus. Everybody with lupus, if you really have lupus, you need to be on hydroxychloroquine. Why? Because of just 5 facts. One, it decreases the incidence of cardiac problems in neonatal lupus in patients who stay on it during their pregnancy. It lowers blood glucose and improves insulin resistance, and it's been shown to decrease the rate of incident diabetes in patients who are on it chronically. It's been shown in lupus and in rheumatoids. It decreases thromboembolic events and the consequences of that. It overall improves lupus survival and overall decreases lupus flares. So this is one of our first. It's very effective at skin and joint manifestations of lupus. I wouldn't use it necessarily to treat nephritis, but it turns out nephritis patients do better if they're also on hydroxychloroquine. You need more therapy for nephritis. So it is a very effective agent, and now it's being used with the coronavirus infection, and largely because of the supposition that it may work, and early uncontrolled reports out of China. And then this report that came across in early March, this is called often the Marseille study. It's looking at hydroxychloroquine azathioprine in COVID patients. They enrolled 42. They only report data on 26. And that's 26 who received hydroxychloroquine. And then there was only a few who got azithromycin. And it's not clear why they got it. The problem is that they dropped six of the patients out of the 26 to give you the graph on the right. So it looks really good that it is that green bar of people on hydroxychloroquine and azithromycin that have seroconversion of their COVID test, and that the blue line does pretty good, 70% improvement in seroconversion. But the bottom line is this is a badly done study. It's observational, a lot of holes in it. They used higher doses of hydroxychloroquine. It's not clear how they use these azithromycin. And they suggested it should be used, and that's why everybody wants it. Everybody's using it. It's now part of the protocol when you go into the hospital in many situations. This should not be used, by the way, in COVID patients who are being managed as an outpatient. There's absolutely not enough evidence to warrant outpatient management with hydroxychloroquine. And I'm going to show you the inpatient data that says that it really isn't very good either. This is the results from a VA study. It's retrospective. It's only a preprint. I'm sorry for that. It just basically looked at patients in their system, and they had like thousands of patients, and in their system who received either hydroxychloroquine or hydroxychloroquine and azithromycin. So there's a reporting bias that's inherent here. They were looking at a primary endpoint of either intubation, mechanical ventilation, and or death. So they basically found worse outcomes in those who were on hydroxychloroquine either alone or in combination when you compare it to those that were not on it. Again, the risk of death was 2.6-fold higher if you were taking hydroxychloroquine, and they summed that up by saying this retrospective study should caution against the routine or unwarranted use of hydroxychloroquine. The chloro-COVID study was done in Brazil. This was a study that was supposed to enroll 444 patients, but an interim analysis disclosed in the first 81 that there were 11 deaths. In this protocol, they were using high-dose chloroquine. Again, usually it's 450 once a day. This is 600 BID for 10 days. And then there's a low dose of 900 one dose, and then 450 a day for 4 days. The high-dose group in the first 81 patients included, they tend to be older, and they tend to have more cardiovascular disease, 12% older versus 0 in the normal dose, and 18% in the high dose versus 0 in the low dose. Yes, the high dose group did have more QTc prolongation, 19 versus 11%, but none of these people died. There were no deaths in this group. Seemed like all the deaths were related to the comorbidity issues above, and then you look down here, 3 out of the 5 high dose patients who had background cardiovascular disease that died. Again, overall death rate was 39% with high dose and 15%. They suggested that we should have skepticism about these claims with antimalarials. Next comes a report from yesterday's New England Journal from 2 New York City hospitals looking at the almost 1,400 consecutive hospitalized patients. They excluded 90 of them to get to 1,376. They looked at the patients in their system who were treated with either hydroxychloroquine or not. The endpoint here was intubation or death. Again, 59% of patients were on hydroxychloroquine. They got 600 BID on day 1 and then 400 a day for 5 days. So it's kind of high dose, but it's short-term therapy. The chloroquine patients by selection were more severe at baseline. There was a lot of background use in these 1,400 patients with remdesivir. 30 patients were enrolled in a Sorilimab IL-6 study. They talked about azithromycin, but they don't tell you the numbers of patients. The bottom line was the endpoint was achieved, meaning death, in 25% of patients on hydroxychloroquine. And looking at the plot on the right, you can see there really is no difference in survival or intubation if you were on hydroxychloroquine or not. So clear from this study, while there's not a bad signal, there was not a good signal either. Hydroxychloroquine didn't affect the outcomes. So what about cardiotoxicity? Again, in this particular study, it was seen in a number of the deaths that were accounted for. We worry a lot about retinopathy, which is much more common in chloroquine than hydroxychloroquine, which is why nobody uses chloroquine anymore. Neuromyopathy, maybe 1%. We don't know the risk of cardiomyopathy or cardiotoxicity in our patients. When I looked this up, it looks like many, the first finding is that of a complete heart block. But they can get either systolic or diastolic dysfunction, cardiomyopathy. Biopsy is best confirmed by typical findings on endomyocardial biopsy with these lamellar and curvilinear bodies and vacuoles and PS positive granules within the cytoplasm. But there is no definitive test other than a biopsy, and there is no definitive treatment other than the withdrawal of the antimalarial. So I want to, though, reinforce that these reports of cardiotoxicity with chloroquine, hydroxychloroquine, so far seem to me to be more related to host factors, age and pre-existing cardiovascular disease, rather than the drug. But it is possible the drug could be to blame. And might that be because they're getting high doses, sometimes for up to 2 weeks, sometimes for less than 1 week, but they're also being given to gravely ill patients. And our doses in lupus and RA, we tell our patients and our docs, don't stop hydroxychloroquine in the COVID era. Don't stop it if you, or go to the hospital. Don't stop it if you think you got COVID. Just keep going with it. It's unlikely to be a player in the outcome of that individual. And there are a number of reports on that that I could talk about later. So again, there's a timeline here. You know, the president advocated it from the podium, saying it's approved. It wasn't approved at the time. 2 weeks later, the FDA issued an emergency use authorization. But you fast forward through a lot of trials, a few trials actually, and you can see on a few weeks ago, 2 weeks ago, the FDA, Health Canada, and also the EMA in Europe all warned and put out a safety warning about the use of hydroxychloroquine and chloroquine outside of hospital use and outside of a clinical trial. And they're worried about doctors hoarding this and giving it to their aunts. They're worried about patients. It's amazing to me how many of my patients who were previously non-compliant with hydroxychloroquine are calling, wanting to get back on it during the COVID era. It's done wonders for patient adherence. But the bottom line is it shouldn't be used for the prevention or the treatment of COVID. And that's basically said in some of the guidelines. So the ACR, American College of Rheumatology, came out with guidelines on April the 11th. They basically say, don't stop your drugs, continue to use steroids or whatever you're on. If you're on ACE inhibitors or ARBs, you should continue them. Treat patients as you normally would. If someone's COVID exposed, you can continue many of the medicines and wait until the results come back. And you can temporarily hold these drugs, but a lot of the drugs that they're holding have incredibly long half-lives, so it's something that looks good on paper rather than being truly effective. For someone who is truly infected with the coronavirus, the ACR says that you should continue hydroxychloroquine based on the suppositions that I mentioned heretofore, but they say you should stop sulfasalazine, methotrexate, leflunomide, a DMARD, immunosuppressants like azathioprine, cyclosporin, mycophenolate, biologics like TNF inhibitors, and JAK inhibitors. They say if you're on an IL-6 inhibitor, you could continue it, but they say, and for no good reason, they say stop nonsteroidals for severe respiratory symptoms. That is not an endorsement of the French guidelines favoring acetaminophen over nonsteroidals, which is also kind of baseless. They put this in there saying, well, mainly people who are sick and in the ICU are not going to be on nonsteroidals anyway. And that's probably true, but there's not a good reason to stop nonsteroidals. The NIH expert guideline committee had 34 physicians and whatnot who came up with a lot of, I think, reasonable statements. The second bullet says that no drug is safe and effective in the treatment of COVID. The third bullet says there's no evidence favoring the use of hydroxychloroquine for the treatment of COVID or prophylaxis against COVID. And then in their guidelines, they sort of divide people up based on mild, moderate, severe disease, and critical disease. And the bottom line in all of them is that there's no sufficient data to warrant for antiviral therapy or for an immunomodulator of any kind. And that's based on expert opinion. They do, of course, say that patients who are hospitalized and those that are on protocols can get these drugs, but they want to be clear about the evidence. The evidence is basically nil. They do say that patients who are on chronic doses of steroids should continue on those same doses and not alter them. You should not use steroids to treat COVID unless you're covering either shock or it's part of your protocol to treat ARDS. You should continue statins, ACE inhibitors, and ARBs, and again, use whatever you want to use for the control of fever. So we're considering cytokine storm syndrome, and the big player there supposedly is IL-6. I'd like to say it's not quite that simple, but IL-6 is clearly a big player. It's a pleiotropic, meaning a lot of cells give rise to IL-6. It has mainly effects on hematopoietic cells and hepatocytes, and can mediate inflammation and damage, as well as any other of the pro-inflammatory cytokines. This cytokine has been around since the late 70s. Kishimoto in the 80s actually really wrote a lot about this and initially described this as being B-cell differentiating factor. It promotes B-cell differentiation. It also has T-cell activation properties. It stimulates the liver to make acute phase reactants and turn off albumin and whatnot. And it has significant effects on bone by inducing osteoclasts. So again, this is a very powerful cytokine that, if produced in excess, can either maintain homeostasis, but too much can be a really bad thing. IL-6 shown on the left here in panel A will bind the IL-6 receptor and GP130 to lead to transmembrane signaling, and what happens down in panel D with JAK-STAT activation and many of the pathways you need to generate many pro-inflammatory cytokines. In panel B, we see that circulating IL-6 can also bind to soluble IL-6 receptors, which are easily shed. And in the case of TNF, when TNF binds a soluble TNF receptor, it's sort of counter-regulatory. Here, it's not. It's actually it's actually an agonist. And now the IL-6 plus IL-6 receptor will preferentially bind to GP130 on the cell and induce the same transmembrane signaling. So it is this signaling that you look to interfere with. You could have antibodies against IL-6 directly, but the two commercially available antibodies, tocilizumab, also called Actemra, and sarilumab, also called Kevzara, do their activity by binding to the IL-6 receptor. And in doing so, prevent the engagement of circulating and/or cell-bound, and therefore blocking the signal transduction necessary to generate a hyper-inflammatory state. So a few years ago, with the advent of CAR T-cell, this very tailored therapy for acute lymphoblastic leukemia, largely used in kids and adolescents, they found that a high percentage of these kids, when you gave them these CAR T cells, had a cytokine release syndrome, where they've got very inflamed and had many manifestations. In this one study, one of the early studies, 39 patients were treated with CAR T cell, and half of them developed grade 3 and 4 cytokine release syndrome, and that's with high fevers, hyperferrotemia, organ dysfunction, either heart, lungs, kidneys, liver, etc. Basically, it causes a storm of cytokines, capillary leak that leads to both tissue hypoxia and hypotension. Again, they find high levels of cytokines in these individuals when they actually, in this particular study, gave 13 of the 18 tocilizumab. They all had rapid improvement, both clinically and laboratory-wise, suggesting that this could be the effective therapy. And then this quickly became, based on very little data, it quickly became an additional indication for the use of Actemra in patients who are receiving CAR T-cell therapy. And it's being used both ways, meaning it can be used before you're giving it or as you're giving it, or you wait until they get symptoms and then they give it, where it's been shown to be effective. So the cytokine release syndrome is not that dissimilar to the cytokine storm syndrome. And I'm going to show you the next slide, is not that dissimilar to HLH and macrophage activation syndrome. And so here what we're seeing, of course, is that the cytokine storm syndrome manifests its worst part as ARDS and multi-organ dysfunction that leads to a very high risk of death, and I'll say a 40% chance of death, according to many sources. There's an excess of many cytokines being produced from many different cell types, but the pro-inflammatory cytokines stand out. IL-1, IL-6, IL-8, TNF, the chemoattractants, the chemokines that are seen. So obviously it makes sense to target these pro-inflammatory cytokines, and IL-1 has been targeted in patients with the macrophage activation syndrome with good success. IL-6 has been used in the CAR T-cell associated cytokine release syndrome. And in familial HLH, where there is actually a defect in the perforin gene that gives rise to basically unbridled T-cell activity, gamma interferon, that this gamma interferon that drives most of the manifestations we see in HLH, when they use gamma interferon neutralization in virally infected mice with the cytokine storm syndrome, they have prevention of disease or amelioration of disease. The good news here is that you can inhibit gamma interferon now with a commercially available monoclonal antibody called Gamifant, or emapalumab. It was approved in 2018 for patients with HLH. It has been studied in kids with macrophage activation syndrome. It has been studied in kids with systemic onset JIA who develop MAS. And it's fairly easy to use. It's basically a single dose and then twice weekly, and has really dramatic reductions in gamma interferon and labs and clinical improvement. Now, these people are really, really sick, so the side effect profiles kind of look ugly, but it's ugly as part of them almost dying. The main biomarker here, because it's very hard to measure gamma interferon, is CXCL9, which rapidly goes down to almost zero in a few days. So as I intimated before, it is my belief, and you can find people to argue with me, that cytokine storm looks like macrophage activation, looks like the hemophagocytic syndrome, also called hemophagocytic lymphohistiocytosis, or HLH. All these people have the same, very high fevers. And by the way, their fevers are different than, I make a big thing, I love to talk about Still's disease, where they have quotidian fevers. It rises above 102 once a day and returns to baseline every day. And it's this spiky thing that happens like clockwork. It's a quotidian fever disease. But in this situation, when a patient with Still's disease, kid or adult, gets macrophage activation syndrome, their fevers stay high. So it's a sustained fever. It may bounce around like that, like the one we just saw, where it bounced around at 103, 104, 109. That blew my mind. I had never seen one that high. But that's a key factor here. Hypotension and organ dysfunction, often with CNS manifestations. The hallmark is the hyperferritinemia. Now, the definitions of that vary according to criteria. And I don't think criteria apply. Criteria apply if you're doing studies. Criteria apply if you're doing retrospective analyses. But the trends here, you need to identify right quick, meaning that you need to see that ferritin going up there, cytopenia developing, and immediately suspect this and institute therapy. But a ferritin above 5,000 is usually the recommended minimal amount for a lot of the HLH criteria, but along with this goes very high elevations, 5-fold or more elevations of LFTs. Along the way, at the exact same time, they developed a reversal of what was leukocytosis to leukopenia associated with a worsening of lymphopenia and thrombocytopenia. You need not have all of them, but you should have evidence of a real reversal of cell counts here. The markers that you should look at is LDH and IL-6 is, you gotta wait for it to come back, but LDH and C-reactive protein are readily available and should be sky high. A friend of mine, unfortunate friend of mine, best friend of mine, kills me to talk about it. He's in the hospital in New York City, intubated for 52 days now. His presenting COVID symptom was, respiratory symptoms, rapidly needed intubation. His initial CRP was over 500. So the CRP should be really high. Interestingly, while the CRP is really high, the SED rates, which might have been high, drop because they drop their fibrinogen levels. So they have evidence of coagulopathy with high D-dimer levels, as this patient did. The issue of having evidence, bone marrow evidence of hemophagocytosis is very important for the HLH diagnosis, but it's variably present in macrophage activation syndrome, and I can't tell you anything about cytokine storm. I can tell you macrophage activation syndrome is sometimes present, it's often present late or terminally, but early on when you diagnose them, it's often not present. Only repeat bone marrows would disclose that. High mortality rate, up to 38% in kids, up to 40% in adults, and this is treated by either IL-6 inhibition, IL-1 inhibition, and now with emapalumab. Before emapalumab, the idea was you would use cyclosporin and etoposide. Why? Well, because the way the sequence that you see on the right, you have activation of T cells, often that's toll-like receptor mediators. You know that the innate immune response is activated by DAMPs and PAMPs, PAMPs being pathogen-associated molecular patterns, DAMPs being damage-associated molecular patterns. TLRs are engaged by these. And because of that, you then have activation of the inflammasome and early steps in the inflammatory response and the innate immune response. But then this leads to activation of cytotoxic T cells and CD8 cells. And what should happen then is that they should generate perforin and use perforin and other modalities to kill antigen presenting cells. But that doesn't happen. That gets interfered with. And so these CD8 and NK cells stay around. The antigen presenting cells, which are infected, stay around. Cytokines continue to be made. And the most abundant one, and maybe the most proximal one, is interferon gamma. But what happens is it gives rise to the syndrome. If you have IL-10, a deficiency of IL-10, macrophage activation syndrome goes crazy. If you have an excess of IL-1, macrophage activation syndrome goes crazy. So those are your targets. You could use supplemental IL-10. I don't know if anyone's using that. You could use anakinra, which is basically IL-1RA to inhibit IL-1, and IL-6, or you could target gamma interferon. All of these are now in clinical trials. So the treatment of cytokine storm requires, number one, that you make the diagnosis as early as possible. There are criteria that you could refer to. I don't know that they're really important. I don't know this patient, for instance, would have even met criteria, although he would have come close. So I look for, to me, the red flags are the cytopenias, the hyperferritinemia, the really high LFTs, LDH, CRP, and SED rate going low. And again, I see more in my cases in patients with Still's disease. The treatment is at the top left-hand corner, cytokine targeting, and it's IL-1 or IL-6 or maybe even gamma interferon, but again, these are in clinical trials. And then second-line therapies are meant to control what I showed you in the prior slide, meant to control all this T-cell activity, an abundance of T-cells to knock them down. You do that with cyclosporin or direct T-cell inhibitors, etoposide, sort of an indirect T-cell inhibitor, and now JAK inhibitors, because they actually get in the way of gamma interferon and have a number of other anti-cytokine effects, including anti-IL-6. These are in clinical trials. Steroids should be used. If you recognize someone with cytokine storm syndrome, personally, I would hit them with pulse doses, a gram of Solu-Medrol daily for 3 days at least, while instituting one of these therapies. Now, the problem with this is that there are patients with Still's disease on IL-1 or IL-6 who have developed macrophage activation syndrome. So does that mean it's a cause? No, it means it wasn't enough to prevent it. But so if your patients are not on this, you could certainly use them. All guidelines say treat the underlying cause, whether it's an autoimmune, autoinflammatory, or infectious or malignant cause. And then you have to manage the complications and supportive care as a way of getting out of it. If they can get through it, they'll do okay, but there's often a lot of damage. Now, the argument about my including all these cytokine-driven syndromes together is argued against by these different recommendations for familial HLH and EBV HLH and JIA-associated MAS, et cetera. You can see there are a lot of different effector molecules, and then their treatment may be different. So, gamma interferon neutralization may be important in familial HLH and maybe also in MAS. But B-cell therapies are warranted in EBV-driven HLH. IL-1 therapies or IL-6 therapies might be driven in systemic JIA. And clearly in the cytokine release syndrome, IL-6 blockade. But again, we don't have the luxury of often being able to differentiate all of these as finely as some people would like to. And I think you go with what you're familiar with and what will work. I think it's good to use IL-6 inhibitors, but why not? IL-1 if you couldn't use an IL-6 or didn't have access, or why not a JAK inhibitor to continue on the success of maybe one of these cytokine inhibitors. So the IL-6 inhibitors were available. Tocilizumab was approved in 2010. Sarilumab was approved in 2017. And basically, I have to move on because I got to get to the end here. But the idea here is that these are very effective. This shows you what happens to CRP in RA patients treated in the function trial. Look at the green and yellow bars. It drops within two weeks. In fact, it drops within 3 to 5 days down to 0 using an 8 milligram per kilogram dose of tocilizumab. Tocilizumab has been used in systemic JIA. I show you this because the dosing here of 8 milligrams by body weight if you're a kid, if you're an adult, and up to 12 milligrams if you're a kid, are recommended doses. The same doses, by the way, are recommended for the cytokine release syndrome, suggesting that if you're using tocilizumab to treat cytokine storm, you need high doses, at least 8 milligrams per kilogram, and I wouldn't be afraid to go higher if I could actually get the drug. But the drug works briskly and very well. These are the results of IL-6 inhibitors in clinical trials. It first came out with a 21-patient uncontrolled study out of China. Febrile hospitalized patients, all with elevated IL-6 levels. When they were given tocilizumab, 19 of the 21 were discharged within 2 weeks. Wow, this drug looks really good. Next, the sarilumab trial, a press release recently of 358 patients in a trial where they're either getting normal dose, 200 milligrams, or high dose sarilumab. And what they showed in this trial, I'm sorry, I wish I could go over it in detail, but we're getting close to the end. They showed in this trial that the severe patients, meaning the ones who are not yet intubated, didn't do as well as the critical patients, the ones who were intubated. And while many people were discharged, there were higher death rates when you didn't use the drug in the critical patients. So, and now there's a report out of France with a tocilizumab trial, 129 patients who got tocilizumab or not, and those who got tocilizumab had fewer deaths and need for ventilation. You can inhibit the innate immune response, and that would include monosodium urate, giving rise to damage-associated molecular patterns and activation of inflammasome by basically using colchicine. And colchicine is now in a clinical trial trying to treat early patients with SARS, COVID-2 infection. This is coming out of Montreal Heart Institute and also NYU and UCSF. It's again a 10-day or 27-day trial to see if it changes the outcome. IL-1 inhibitors have been used anecdotally with a case report showing some benefit, but in this middle bullet you can see that just a report from just a few days ago that 29 high-dose anakinra patients, that's 200 milligrams given IV, versus 17 control patients assessed on day 1. This is the CRP levels in the anakinra on A and CRP levels in those that were not treated. Basically, survival was better on anakinra, suggesting it could be used in severe COVID patients. JAK inhibitors, baricitinib's out there. Baricitinib, a JAK1 inhibitor, works by inhibiting, over here is baricitinib, it inhibits AAK1, which is required for endocytosis, and also another one called GAK, and by inhibiting the COVID virus is not going to get viral entry into the cell. There are trials in progress, and one has actually been published, and that's this trial here. The results basically say down here on the bottom that those that received control therapy, no baricitinib, had no significant changes, whereas the baricitinib patients had improvement in clinical and laboratory parameters and had more discharges from the hospital. I think I'm going to stop there and just leave you with my belief that our patients in rheumatology are not really at risk. And I think that's because they're well controlled. There's a report in the GI literature, a cohort analysis that shows that their COVID patients who got infected, the only risk factor amongst them was disease activity. It wasn't their drugs. And they use the same biologics that we use. So I have a lot of evidence that says, number one, our patients have been hospitalized, but probably at a much lower rate. 2, that patients on hydroxychloroquine and on IL-6 inhibitors have not particularly been benefited from that because some of them have had some severe courses, including deaths. But anyway, I'll stop there and we can go to questions if we have time.
That's great. Wonderful. Thank you very much. That was a great overview presentation of the medications that we are using and don't know the evidence for, and other medications that we may use once we have evidence, or also understandingly being limited by availability. So there's a lot of questions that I got here, and I imagine there will be more coming in. So for Dr. Kush and Dr. Osorio, one of the first questions that came in is basically how can we, is there a way to be treating patients early in the course of their disease so that they don't progress to the point of having cytokine storm or having this immune reactive state that leads to the complications that we're seeing?
I mean, I think the whole issue in the management of the successful management of severe COVID centers around timing. And I don't view that the drugs themselves are as nearly as exciting as the issue of timing. And like, when should you use a JAK inhibitor? You want to use it very early as a preventative agent, where you can affect endocytosis and viral access, and then viral replication, or do you want to use it after as an adjunct to cytokine storm? So right now, the prevention trials that are out there, there's the HERO trial where hydroxychloroquine is being given to healthcare workers who've been exposed and those who haven't been exposed, to see if it prevents the progression or infection rates. There's the Colchicine trial that I talked about that is being used, and there are other preventative trials with hydroxychloroquine. That's it for as far as early intervention. Now, again, timing of other interventions that I hope is going to be worked out in trials.
Great. And the follow-up question by the same individual talked about, since acidosis seems to accelerate the viral replication, could having an alkaline milieu early in the COVID infection help? Thinking about this patient, Carlos, that you presented, who became severely acidotic with a pH below 7.
Yeah,
I mean, as far as for the patient that I presented goes, his acidosis occurred very late. It seemed to be more mild during the course of the majority of the hospitalization. It was really at the end, and I'm not sure how much of it was from renal failure. But as far as anything preventative or to try to run the patient more alkalemic, perhaps, that I know, I don't think I've read anything to suggest treating in that fashion.
Yeah, alkalinizing the patient seems to be an issue for those people who are hypercapnic and trying to manage that, and other issues. But I don't know how or where that could be used in early infection. I haven't read that was an approach at this point.
There's a question about tocilizumab, and I guess specifically in the patient, Carlos, that you brought up, was there any thought that his decline was related to the use of tocilizumab? And because there have been some attendings that have observed a decline after using tocilizumab, and I think one of the big concerns that we even discussed this morning on rounds was secondary infections after using tocilizumab. So Carlos, I don't know if you have a statement about your patient, and Dr. Kush, if you have a thought in general about tocilizumab.
Briefly on my patient, I mean, it's tough to say. We discussed earlier today about how these patients with treatment with tocilizumab can then go on to develop these secondary infections. With my patient that I presented specifically, it's hard to tell. There was no evidence of what's that? Oh. There was some thought of it, but the patient was already treated. I have here the attending with me who was seeing that patient as all this happened.
Yeah, I had some concern of unmasking viral myocarditis, since it was he seemed to have that manifestation shortly after tocilizumab. But again, we don't know, a direct length of time that he was already infected. It could have been too late in his course, or it could have been too early in the course that we gave him, since so many people have been advised to stay home and don't come in unless you have, moderate to severe symptoms.
So about 5 slides after, I was going to talk about the issue of infection and biologics. Number one, most people are worried about infection and biologics because you'll listen to television, and that's all it talks about. It doesn't really talk about any data. The data is really about 1% for most of the biologics on placebo and 2% on a biologic. It's a non-significant doubling. It doesn't really matter very much. And we're talking here about serious infections, almost always bacterial infections, and specifically with tocilizumab and IL-6 inhibitors, there's no evidence of viral reactivation really with tocilizumab. It's very, very low. Even shingles events aren't much higher than they are for other drugs. JAK inhibitor shingles events are very higher, in fact, and viral reactivation is an issue. Let me show you one slide I think is important that you should consider when considering this particular issue. And that's a study from the German Biologics Registry, this slide I'm showing you here. And what we're looking, just look at the first row. These are RA patients, like 10,000 of them, and they're either treated with DMARDs or TNF inhibitors, looking at whether a TNF inhibitor increases the risk of infection. And there's 3 groups, those that are on low-dose steroids, 7.5 to 15, and greater than 15 on the far right group. And you can see that adding a TNF inhibitor does almost nothing to risk. I mean, it's just a negligible, non-significant, not even doubling in most of the cases. But look at that back row, that purple row. Who are the ones where it would add to risk? And that's the purple row. Who are the purple row? They're the people who have 3 comorbidities that have been known to increase risk of infection: age, chronic lung disease, chronic renal disease, number of prior treatment failures, prior SIEs. Any ID guy will tell you if someone had a hospitalized pneumonia in the past, they're likely to get it again and die from it the second time around, much more so than not. So the idea here is that it is the background comorbidity. So yes, giving IL-6 or IL-1 inhibitors to your patients in the ICU when they're crapping out, it could impose risk for more bacterial infections. But to not give it takes away the potential for improvement. So it is a very, very stressful risk benefit analysis that one has to go through.
Yeah. Jared, since you're right there, I don't know if you want to ask your question that you had.
Yeah, do you think there may be any role for plasmapheresis if you have patients that seem to be refractory to DMARDs?
We're refractory to biologics here, right? Or hydroxychloroquine. No, because I don't think much of this is in the way an autoantibody mediated problem or immune complex mediated problem. And many of the cytokines are too small to really be affected very much by plasmapheresis. So no, I mean, the other things that people have talked about is the use of steroids, and they come with I mean, of all the drugs you use that might have caused the infection or reactivation, it might be steroids. You know, and the data for that is overwhelming. IVIG has been advocated in some, but that's like last ditch voodoo medicine that no one knows really how well it works. It has worked in a few people with MAS. I don't see it playing a role in patients with COVID. But no, plasmapheresis probably not.
Okay. There's a question brought up, and this, you know, what's great is we have lots of names on here asking questions, names that I know from the department, and we clearly have lots of people that are in on this video, this conference that that we don't know from outside. So I'm really happy to see so many individuals from across the hospital, the medical school, and even outside of the area. So there's a question about, and this is something curious about, asthma doesn't seem to be on the list of COVID-19 risk factors. And so that could apply to, you know, Carlos as a pulmonologist, and Dr. Kush as, you know, your insight into the cytokine storm, if there's any thoughts as to why asthma may not be a risk factor like we thought it would be.
Well, I would say first, from the autopsy series I mentioned, it is a risk factor. It was listed as one of the top 4 or 5 comorbidities that were seen. So I would consider people with chronic asthma as being at risk, especially if they're not well controlled. I think it's not being uncontrolled or having active ongoing inflammatory disease, I think in many patients can be a significant risk factor that applies to COPD and asthma as well. But I have seen asthma show up on lists. It just doesn't seem to get as much play, maybe because we're seeing worse outcomes in older people.
Yeah, I think in the, correct me if I'm wrong, but in the JAM article that looked at a few thousand patients in New York City, where they looked at characteristics, comorbidities, and outcomes in those patients, that asthma wasn't listed as one of the risks. Maybe that, you know, that's where it's probably coming from. I don't know, Carlos or Jared, do you have any thoughts?
I mean, we've been collecting and we have unpublished data from a multi-center database that will show asthma is a risk factor, but it's not as high as some other comorbidities. Okay.
In terms of use of, you know, cardiac complications from hydroxychloroquine, there was no comment on the risk for Torsades de Pont VT in patients with hydroxychloroquine, because it's been reported in some patients, some COVID-19 patients. So is this dose relation? Is this independent? Is this just the drug? Is this something specific to use of the medication in our COVID patients?
Well, in that core COVID study from Brazil, where there were a bunch of deaths and QTC prolongation was higher in those on the high dose of the drug compared to low dose. Number one, there were no deaths in that group, and number two, there were no instances of Torsades de Pont arrhythmias. And if you look at a number of the studies that have been done on chloroquine and hydroxychloroquine, it's been rarely mentioned. I can think of one mention recently where one case was reported. So again, if it was going to be a bigger issue, or as a sign of cardiotoxicity of the drug, then I would expect to have seen it more than it has been reported so far.
Okay. There's a question here, and you know, try to paraphrase it, but a role for reducing tocilizumab when the inflammatory markers are not high after a previous dose has been given. And I would say, even, you know, regardless of whether there's 0 doses or 1 doses, how are we using our inflammatory markers, particularly here, we're mainly using CRP and D-dimer, to decide whether to give tocilizumab or not the first time and the second time?
Yeah, I mean, if you don't get first off, you should be using 8 to 12 milligrams per kilogram as your dose. Round up or round down to 100 milligram doses, and then It's a fairly fast infusion. If you don't have a dramatic drop in 3 to 5 days, I would give a second dose or move on to another therapy on day 7. I mean, I haven't seen people give a lot of hydroxychloroquine, a lot of tocilizumab, but I have seen trials where they've given 1 dose followed 2 weeks later by a second dose. And these are, of course, are given IV. But for most of these studies, it's been a single dose of either sarilumab or tocilizumab.
Great. There's a question from one of the pediatric critical care doctors, and she mentioned, and I read about this the other day, about a lot of patients like this in New York City, but they're seeing children coming in with Kawasaki type myocarditis syndrome that's thought to be COVID related. And they've been mostly treating these patients with high-dose steroids and IVIG. And do you think there's a role for toci or anakinra in these patients?
Yeah, I mean, I'm watching this, and it's one of these situations where I'm ashamed to tell you what I know, because what I know is coming from like tabloid publications rather than medical journal. And I first wrote about this about a little over a week ago. It was something out of truly a British tabloid, and then followed up with a New York newspaper, and a few cases, and now it's like 15 to 30 cases, depending on who you count. And they do look like Kawasaki's, but kids are supposed to have a lower risk of infection, milder disease, very rare that they end up dying or end up in the ICU. But there certainly are cases, and is this going to be the small subset? I don't know. So yes, I think that they should be treated as Kawasaki's normally would be. I would more likely use an IL-1 inhibitor than I would IL-6. The advantage of the IL-1 inhibitor is that it has a short half-life and it works fast. The anakinra has a very short half-life, works very fast. Canakinumab, the other antibody, doesn't. I mean, that's why you take it every 8 weeks or every 4 weeks. But however, anakinra is given as it's usually a sub-Q, but it can be given IV as 100 or 200 milligrams, and then you could repeat it the next day and whatnot. So again, I probably would favor of anakinra if the other ones, IVIG and aspirin and usual measures, didn't work.
Okay. Great. There's a follow-up comment that just came in about asthma, and it's been suggested that patients with asthma, especially those with atopy, have downregulation of the ACE2 receptors, which may spare them from severe COVID. But again, we're also seeing here from what's being spoken about, and there was another comment that asthma is more of a risk factor than maybe reported in some articles. So it was a wonderful presentation. You can't see the number of positive comments that are coming through here. So Carlos, Dr. Osorio, thank you so much. It was a fantastic patient presentation. And Dr. Kush, it was also wonderful to have you here remotely. I hope you stay safe. To remind everybody, we'll be here next week for another Grand Rounds. And next week's conference is going to be with Andrew Brooks. Andrew Brooks is a professor here at Rutgers in the Department of Genetics, who helped to develop the saliva testing for COVID-19. So look forward to seeing you all next week. Thank you very much.
Thank you.